Okay, so I'm going to start with the basic measurements that we want to take, which is the threshold, the sensing, and for some people, a new one, which is the impedance. And it's not really a new one because when you do a threshold check, it will also do an impedance check at the same time. To illustrate this, I have programmed the device to VVI mode at 40 beats a minute. So VVI is the mode is always at the top next to the battery status. The rate is always the second one down, and there's nothing in the atrial panel because we're in VVI mode. We've just got numbers in the white panel because we're in VVI mode. And we have a flashing light in the white panel indicating we're sensing. And I know that because the light is next to the sensitivity. You can see here VSense, but it's next to the sensitivity number. I have another light here which is not on at the moment, and this is to indicate when the device is delivering pacing pulses. And as you can see from the ECG, there's no pacing pulses, so this is not flashing. What I'm going to do is to do the three measurements in VVI mode. So VVI, 40 beats a minute. If I want to change a value, I just rotate these controls at the side. I can make the output bigger or smaller, and the same with the sensitivity. So let's start with sensing. And the reason I'm going to do that is because I'm not pacing at the moment. VVI is typically used as a backup kind of mode at lower rates. So VVI at 40 is something you typically see. It might be 50, might be 60, but a rate which is lower than the patient's intrinsic rate. And to sense, all I do is put my finger on the pause button, I press and I hold, and it starts to measure the size of the R wave from inside the heart. And I can see here my R wave is 6 point something. After 10 seconds, it has enough information to give you a reading, and that says 6.6. And this is not something that we need to do accurately. We don't have to get a calculator out to calculate what we should do with that number. We just need to know that it's over 6 millivolts. So that's the size of the R wave. So then we look at the sensitivity, and anything bigger than 2 will be sensed. So 6 is definitely going to be sensed. And the rule of thumb is to set the sensitivity somewhere between 1/3 and 1/2 the value of the R wave. So I've got it here at exactly 1/3. 2 is 1/3 of 6, so this is set exactly correctly. So then I move on to thresholds, and typically what I do with threshold is I take my voltage and I reduce it down slowly until I lose capture, but I do have to be paced. So I'm going to move the rate up to something like 10 beats higher than the intrinsic rate. It's not the exact pacing rate is not important, so I'll leave it at 78. That looks pretty good. I can see these broad complexes on the ECG after my pacing spike, so this tells me that each of these pacing spikes are being captured. So this all looks pretty good. I then start to drop the voltage. So I go 5, 4.8, 4.6, but as I'm dropping the voltage, another number appears here, and this is the impedance. 548 ohms is the impedance. I don't do anything with that, I just write it down at this stage. And then I continue dropping the voltage. I know where the threshold is, so I'm going to come down quite quickly, but you will come down much more slowly than this. And now I'm looking for a loss of capture on the ECG. That's 0.9, 0.8, 0.7, 0.6, and there. You can see there is the loss of capture. That's not, of course, the threshold. We have to go back up slightly to recapture to find the threshold, and that recaptures at 0.7. So then the question is, what do we set the output to? And our advice is set it back where it was and ask two checking questions. So you remember it was at 5 volts, so I'm going to set it back to 5 volts. And the two questions are, is that substantially bigger than the threshold? Yes. And is it at least twice the threshold? Yes. And if the answer to both those questions is yes, we know that we've set the device up correctly. I'll come on to describing why we're recording the impedance at the end of the 3 modes. So I've done my threshold, I've done my sensing check, and I've got an impedance for this patient. You'll notice when I selected VVI, there's a sub mode below it, which is VOO. And whilst it's not recommended to use asynchronous mode pacing, which is what VOO is, sometimes it's very useful on a very short-term basis at high rates to be able to program it. And the way that you do it is all you do is take your sensitivity value and you raise it until it doesn't go anymore. So I'll take it all the way up to 20 millivolts and then one more and then it turns it off. And when I've turned it off, you can see that the mode has changed to VOO. It's not recommended because that's the easiest way to get an R on T is to do asynchronous mode pacing, and that's why it's not straightforward as to selecting the VOO. You don't want to make it easy to get to. You have to be thinking about sensitivity to be able to get to it. So I'm going to put it back to 2, and under no circumstances would you ever leave a patient in asynchronous mode pacing. Okay, so this patient's been checked. We'll move on to a second patient, and the second patient is an AAI patient, and these patients are often paced at high rates. There's the mode at the top, AAI. You can see there's no numbers now in the white panel. The numbers are in the blue panel, and that's because we've just got atrial numbers. The rate is always that number at the top, and my output is 5 volts, my sensitivity is 0.5. And because we're pacing, the light is flashing next to the A stim. So it's next to the output. So you can see here, I've got 5 volts going into the patient. And when I look at my ECG, after every single paced beat, there is a little P wave. Now, an anaesthetist and a surgeon would never choose AAI unless they were pretty certain that the conduction through the heart was good. So you often see, and you hope to see, a P wave followed by an R wave followed by a T wave. The normal cycle of the heart is occurring after the paced beat. And that's what you want. And it's paced at 90 beats a minute to drive the cardiac output. We still have to do the 3 tests. So because we're pacing, we might as well do the threshold check first. So I'm going to take my 5 volts, I start to lower it, and the moment that I lower it, an impedance will arrive at the bottom display, 577. I know it's for the atrium because it says there the atrium, and I continue coming down. As I come down, the impedance will change slightly. Don't worry about that. You want a ballpark figure of what the impedance is. You record it and continue with the threshold check. So I'm coming down pretty quickly. You will come down much more slowly with a patient. And I'm looking on the ECG for a loss of capture. So I'm at 0.9. I'm on the bottom line there. Top line 0.8, 0.7, 0.6. And there you can see it. You see the pulse is delivered, but there's no P wave after it. There is a P wave there, but that's a naturally occurring one, but that is not captured. And a not captured waveform, of course, is not the threshold. You have to come back up a little bit. So there's 0.7, and now we're capturing again. You can see here, this is where we captured. 0.7 is a nice low threshold. And we do what we did in the ventricle. We set it back to where it was, which is where the anaesthetist left it, which is at 5 volts. And then we just ask ourselves a checking question. and that is that substantially bigger than the threshold? And if the answer is yes, the second question is it at least twice the threshold? And the answer is absolutely. It's almost 7 times the threshold. So that's good. You can't really over deliver on the energy. There are stories about being about delivering too much energy, but actually at these kind of voltages that doesn't apply. If we were delivering 100 volts, then yes, that would be too much. But at these kind of voltages, there's no damage to the tissue between 5 or 7 or 10 volts. Okay, so we've done the threshold, we've done the impedance, and now we need to do the sensing check. And there's two ways to do it. One is the nice way, and the other is a bit more brutal. So I'll show you both, and you'll see why. I'll do the brutal way first, and that is literally just to put my finger on the pause button, and I pause, and it stops pacing for 10 seconds, and it measures the P wave. It gathers 10 seconds of information, and at the end you'll see a number appear which is 2.3. That's the height of the P wave from inside the heart. So again, we used the formula of setting the sensitivity to somewhere between a third and a half, and I can see zero point 0.5 is a little bit low. A third and a half, well, a half of 2.3 would be 1.1, and a third would be about 0.7. So I need to be just a little bit north of 0.7. So let's go to 0.8. And as I say, you don't need a calculator for this. You can eyeball it. Somewhere between a third and a half is perfectly acceptable. And you notice that whilst I had my finger on the button, it gathered the 10 seconds, and when the 10 seconds was over, it immediately went back to pacing. And the reason is that it doesn't allow you to stop pacing for more than 10 seconds as a safety precaution, just in case the patient needs the pacing. So that's the brutal way of measuring the sensitivity. And the not so brutal way, which is nicer for the patient, is just to roll the rate down until you get below the intrinsic rate, whatever the intrinsic rate is. I'll just take it down. And you can see on the top line there, I've got a nice intrinsic rate. So I'll leave the pacing rate at 46. And all I do is press the pause button again. I should get the exact same result. And it's measuring here the P wave. It's 2.2, 2.1, 2.3. It varies on a beat-to-beat basis, just like a real patient. 2.4. So half of that will be 1.2. A third would be 0.8. So somewhere between 0.8 and 1.2. And I've got it at 0.8, so that's perfectly okay. And I know that it's sensing okay because there's a green light there. There's no pacing on the ECG, so I know that I'm sensing fine. I take my finger off the button, and I just have to remember to put the pacing rate back to 90, which is where the patient appeared from surgery. By the way, I'm just using 90 as an example of high rates. Anaesthetists will have their own idea of what a high rate is. Some will choose 85, some will choose 95, but I do see a lot of people coming out of theatre set at 90. I can tell that I'm pacing okay because I can see a yellow flashing light. And so I know that I'm delivering pacing pulses, and that matches what I can see on the ECG. Okay, so for this patient AAI, I'm going to give you a little tip. Sometimes when you're doing the threshold measurement, it's sometimes really hard to see the P wave, and that's because of the resolution of the monitor you're looking at. This one's not bad, so I can see P waves here quite nicely, but some monitors it's really hard to see whether you're seeing a P wave, difficult to see whether you're losing capture or not. So here's a little trick. I'm going to do the threshold check, bring the voltage down. We know that it's about, the threshold is 0.7, so I'm going to come zooming down to 0.7 and watch what happens to the lights. So at 1, I know that I'm capturing. because I've got a strong yellow light. At 0.9, I'm still capturing. 0.8, I'm capturing. 0.7, I'm capturing. At 0.6, I know that I've lost. And you see that little green fleck. If there is an underlying rhythm, you will see that little green fleck appear when you've lost capture. And that's the underlying P wave coming through. If you look at it on the ECG, you can see there's a pacing spike, but there's that underlying P wave coming through. And it's not every cycle. Sometimes you might have to wait a few seconds before you see it. But when you see that green fleck, it means that you've lost capture. And then when you regain capture, you see the green fleck disappears. And that's because every pacing pulse is being captured. It's just a little trick. I'm going to put that back to 5 volts, which is where it was. You ask yourself that question, the two questions, is it substantially bigger than the threshold? And is it more than twice the threshold? And if the answer is yes, this patient's good to go. So now we've moved on to another patient. So this is a dual chamber patient. Oh, and I should say that if ever you want AOO pacing, you do exactly what you did to get VOO pacing. You just take the sensitivity, which is this control, you move it all the way to the top, and 18, 19, 20, one more turn, it turns it off and makes it AOO. Okay, and I'm going to put this back. You really don't want to be an AOO. I'll put this back to 0.8. So we're on to the next patient. Next patient is a dual chamber patient, and we're pacing at a high rate, which is very common for dual chamber patients. Coming out of surgery, you want to drive the cardiac output, and that synchrony gives you another 20% of cardiac output. So that's the reason why a lot of single chambers have been replaced in theatres by dual chambers to make sure you have that synchrony. And you can see that we now have a flashing yellow light in the blue panel. That's saying that I'm delivering pacing spikes to the atrium. There's also one in the white panel, so I'm delivering pacing spikes into the ventricle. There's my rate at 90 beats a minute. There's an extra number in the middle. So you can see this 160 milliseconds, and this is the AV delay. And when you turn these boxes on, the default is that they will automatically tie the AV delay to the rate. So watch what happens to the AV delay as I reduce the rate. You can see it starts to stretch. It goes longer and longer, so that by the time I'm at 60 beats a minute, my AV delay is 200 milliseconds. And that's good, because what that's doing is allowing, it takes the headache out of calculating what the AV delay should be for any particular rate, but it also allows you to accommodate the extra length of time that you need for the ventricle to fill when the rates are really low. So at 60 beats a minute, it takes another 50 milliseconds to fill the ventricle, and then you pace the ventricle. If you pace before that, so if you'd left it at 160 milliseconds, then what would happen is you'd be pacing the ventricle just before it's quite full. It wouldn't necessarily compromise the cardiac output too much, but it wouldn't help. I think having that extra 50 milliseconds makes all the difference. And it's not rocket science to look at this and go, well, there are occasions when I don't want them tied together. I do need the AV delay to be longer than 200 at 60 beats a minute. And you can simply do that by rotating the control for AV delay just a quarter turn. And now you can manually change the AV delay until you hit an upper buffer somewhere. I can make it quite long at 60 beats a minute. And I can also make it really, really short. I think short AV delays are most useful in patients like pediatric or neonatal patients. But let's say I've changed that to a manual. and I now want to make it automatic again. So what I do is I go to main menu and I see there's something there called auto. I press the auto button and I'm going to click the square at the top, which is auto AV delay. And you can see the auto comes back here. That's the auto is there. And now when I change the rate, the AV delay will change again. So I'll put that back up to 90 beats a minute. There we go, 90 beats a minute. You can see from the ECG, I'm dual chamber pacing, atrium and ventricle. And I have to do my 3 checks. So whilst I'm pacing, I might as well do the threshold check, which automatically gives me the impedance. So it doesn't matter which chamber I start with, but let's start with the ventricle. I go 5 volts. I start to come down. Immediately I've got my impedance. I write that down and I carry on with the threshold check. And this time the threshold loss of capture is a little more subtle. So I'm at 1 volt, 0.9. I'm looking for a loss of capture on the top line in the ventricle. So there's 0.8. Just go to the second line, 0.7, 0.6, there. So if you look, that was captured because it's got a broad morphology. This was missed. That's just a naturally occurring R wave. And you can see there that it carries on missing. So that's where we've missed, but it's not the threshold, of course. So I come back up again, so 0.7. That immediately regains, so this is where we regained capture, and then I put it back to 5 volts, asking those 2 questions. Is it significantly more than the threshold? And the answer is yes. Is it at least twice the threshold? Yes, it is. I do exactly the same thing with the atrium. 5 volts, there's my impedance. I note it, and I come all the way down, and I'm looking for a loss of capture in the atrium. That's 1.1, 0.9, top line 8, 7, 6, there. So you see that was 0.7, that was 0.6. There's no P wave there, and you see the little green fleck coming through. So that tells you that you've lost capture. So we go back up a bit, 0.7, the green fleck disappears, so I know that I've regained capture, so that's my threshold. And I put it back where it was, which was 5 volts, asking myself the question, is that significantly bigger? And the answer is yes. Is it twice as big? At least twice as big. The answer is yes, then that's all good to go. So we've done the threshold check, we've done the impedance check. I'll just put that back where the front menu is. The next thing we have to do is the sensing check. And again, there's the brutal way where I just press and hold the pause button for 10 seconds. You can do that, it's pretty quick. But I'm going to do it the nice way, which is to roll down the rate and just make sure that I can get down to the underlying rhythm. But something that's really nice to demonstrate here is a quick use of the pause to see if there is an underlying rhythm. So if I pause the pacing, I only need to pause for a few seconds and I can see that there is an underlying rhythm there. So I'm not now concerned about pausing the patient. So I roll the rate down. Let's go down to something below the intrinsic. It doesn't matter what it is. I'm now below the intrinsic. I've got a nice intrinsic waveform there. Put my finger on the pause button, press and hold, and it's measuring the P wave and the R wave at the same time. So it gathers 10 seconds of information, and I'll just check that our sensitivities are set correctly. So 2.3, I should be somewhere between a half and a third of that value for my sensitivity, which is here. So 2.3, half of that will be about 1.2, and a third would be about 0.7. So 0.8 is fine. And in my ventricle, I've got 6.6, so 2 is almost exactly a third of that value. So that's fine as well. I release the button, front menu comes back, and I just have to remember to put the rate back up to 90, which is how the patient left the theatres. Okay, so by the way, if you have questions, just write them on the chat, and we'll address them all at the end. Now, sometimes you want DOO mode, and the way to do it is to exactly the same way as for the single chamber mode pacing. You just take your sensitivities and you move them to the top. So for this atrial sensitivity, I'll take it all the way to the top, and when you turn off the atrial sensitivity, it will give you DVI. And then I can do the same with the ventricle. If I take that all the way up to the top, it will now give you DOO. So I've got both sensitivities switched off. I'm just pacing DOO. You would never leave a patient in DOO mode, but sometimes it's useful, particularly at high rates, to be able to troubleshoot what's going on. I'm going to put these modes back. So I'll put this one back to where it was, which was 2, and this one back to 0.8. There we go. Okay, so there's another mode on this box. There's DDD, VVI, AAI. These are the modes that you're most likely going to use. But there's one at the bottom which is VDD, and this is sometimes called the atrial tracking mode because there's no atrial pacing. And some doctors prefer VDD to DDD because then you don't get any triggering of atrial fibrillation caused by the atrial spike. So you remove the atrial spike completely, but you still get the synchrony from the from sensing the P wave and pacing the ventricle. Particularly useful if a patient has a block of some description. Excuse me. So I'm just going to add third-degree block to this patient. You don't notice it at all because we're pacing the atrium and pacing the ventricle. And now I'm going to VDD mode. And in VDD mode, you can see that my atrial spike has disappeared. But if there was a sinus rhythm, it will track the sinus rhythm. Well, not at 90 beats a minute. So I'm going to bring my rate down to something below the intrinsic. There we go. And you can see now I'm in atrial tracking mode. I sense a P wave, pace the ventricle, sense a P wave, pace the ventricle. And this is a really, really quite nice way of pacing. It's not driving the cardiac output, but it is keeping the synchrony of the patient quite nice. And it also means that I'm not delivering a pacing spike, which could cause atrial fibrillation. It becomes down to personal preference as to whether you like DDD or VDD for keeping the synchrony of the patients. DDD is really useful if you want to drive the cardiac output, and VDD is if you just want the synchrony. Okay, so most things on this box are automatic. There are on many boxes, you can alter refractory periods, maximum tracking rates, but on this box, you don't really need to worry about those things because when you turn the box on, those things will default as to be automatic. If you want to see if they are on, go to the main menu, go to Auto, and there's 3 boxes, and you can see that Auto AV delay is on, Auto MTR, which is maximum tracking rate, is on, but PVARP isn't. At some point before this presentation, we changed that, we switched that off, but I'm just going to switch it back on again. You won't notice any difference to the ECG, you won't notice anything different to the box. But it's really useful to keep those 3 ticks always present. And we can only think of one occasion when you might want to change the auto PVARP to manual, and it's the situation I'm going to talk about next. So let me just turn that back to the main menu. Um, and this is where you can have something called a pacemaker-mediated tachycardia. This is only going to occur when a patient has a um, retrograde P wave. So I'll show you what that is. I can actually set one up. I'm going to put this patient into DDD, and you can see I'm tracking quite nicely here because I'm at a reasonably low rate. But let's say the patient's just come out of theatre and I'm pacing at 90 beats a minute, which is about there. 90 beats a minute, there's my double spikes. This patient, unbeknownst to anybody, actually has a retrograde P wave. So I'll just switch one on and you don't see it. This just looks normal. Here's a pacing spike in the atrium, pacing spike in the ventricle. There's no evidence of the retrograde P wave occurring um, until you have a run of ectopics, or one ectopic can actually cause it. And this simulator behaves like a person, so sometimes I have to have a couple of goes at this. But if I have a run of ectopics, let's do a run of ectopics and see what happens. There we go. I've now started a tachycardia. So there's a retrograde P wave, and there's starts an AV interval, paces the ventricle, which then conducts back into the atrium. So there's the next retrograde P wave, starts an AV interval, and so on. And this is going at the rate dictated by the maximum tracking rate, which at the moment is set to 124. So it doesn't really matter what you do to the rate. This is just going to go at 124 beats a minute. That can be uncomfortable for the patient. You have got synchrony, but it's the wrong kind of synchrony because you're synchronizing the ventricular pace to the retrograde P wave. And you can see it. If you were able to look at the electrogram, you would see it. Let me have a look here. So let's just freeze it. Just freeze it here. So there's the retrograde P wave. It's occurring after the ventricle. So you have a ventricle, retrograde P wave. It's often upside down on the ECG. It's normally a negative kind of waveform. Starts an AV interval and delivers the pace pulse there. So then the question is, how do you break that? Well, there's a couple of ways you could try. I mean, you do need dual chamber pacing in place to sense an atrial P wave and pace the ventricle. So what you can try is just switching to VVI and see if that does the trick. Because really, you're not really sensing a P wave and pacing the ventricle when you're in VVI. And you can see it's stopped the tachycardia. This is fast. This is now pacing at 90 beats a minute, but it's not really got rid of the retrograde P wave. So there's a couple of other things you can try, and you do have to try things. You can't say this will work in one patient and not in another. But switching from VVI and then back to DDD is a very common thing to see if it just jolts it out of that tachycardia. It did jolt it out of the tachycardia, but it hasn't got rid of the retrograde P wave. And then what you can do in DDD mode, just bring the rate down in DDD mode, and that will stretch the AV interval. And at a certain point, let's just see if we can get that. It may jolt it out, and it actually doesn't. It's still tracking the maximum tracking rate. So that's not going to work. So I'm going to put it back to 90 beats a minute. So then the third way of doing this is to go into the menu and find the atrial refractory period. It's actually the post-ventricular atrial refractory period that you're interested in. It's under parameters and options, and you'll see it's matched with the maximum tracking rate. I can select that. The PVARP is in the top part of the menu. The maximum tracking rate is in the bottom part of the menu. And what I'm trying to do is to make that retrograde P wave not be sensed in dual chamber mode. So I start to increase the PVARP. So remember, this is a refractory period that occurs after the ventricular spike, but it's in the atrium. And there you can see I've now got dual chamber pacing. So I've now got the synchrony back. just at that point there, pace the P wave, there's a P wave, starts the AV interval, and I've got my synchrony back. And once you've done that, then the tachycardia disappears. I'm now pacing at 90 beats a minute, which is how the device is programmed, and everything is synchronized again. So you've got to try different things to get rid of PMT. The quick way is switch it to VVI, back to DDD. If that doesn't work, try bringing the rate down, move the rate back up. If that doesn't work, go to your PVARP and increase it. And you can see here, I've increased it from 260, I think it was, to 320. And that's sufficient to stop it. And once you've stopped it, it'll stay stopped. Yeah, you're not going to get that tachycardia back as long as you leave the PVARP at that length. So if I now go to, and you can see here my maximum tracking rate was 124, but I'm pacing now at 90 beats a minute, so that's quite nice. It's quite a nice resolution. If I now go to auto, you will see that middle button there is not ticked because we've come, the moment you manually move the PVARP, you come out of the auto PVARP, and you will set it manually to get rid of the PMT. Okay, now there's no concern about when you're finished with the box that the box will somehow remember that. It won't. The moment you turn the box off completely and bring it back on, the PVARP is set to an automatic value. Okay, so let's talk about AutoSense. And this is a hot topic because what AutoSense does, it allows us to track the height of a P wave or an R wave. And I'm going to demonstrate this in, I'll just pick a mode, let's say AAI mode. So here we are, we're in AAI mode. I'm driving at 90 beats a minute. My sensitivity is 0.8. My voltage is 5 volts. I'm flashing yellow, so I know that I'm pacing okay. So let me just get rid of these blocks because that retrograde is messing up my ECG. There we go, one-to-one conduction. Okay, so I'm now pacing P wave naturally conducted through to the ventricles. Let me just get rid of the electrogram as well. I don't really need that. So here's my ECG. It looks quite nice, pacing the atrium, naturally conducted through to the ventricles, going at 90 beats a minute. And when I turn AutoSense on, what it's going to do is in the intrinsic P wave, it's going to change this sensitivity depending on the measurement it makes of the P wave. So this is how I turn it on. I have to have a short period of intrinsic waveform to start with. So I'm going to take that 90 beats a minute down. That's something below the intrinsic. So now there's my intrinsic. I have to see intrinsic P waves in order to turn this on. So I go to main menu, I go to auto. I'm going to turn on the auto PVARP. I go to auto sense, so I select that. I choose atrial auto sense, and because I'm in AAI, you can't actually choose the ventricle. It won't let you. And when I'm ready, I press and hold the initiate button, and it's going to take some samples of P waves, and it's going to try and work out what the sensitivity should be for the size of those P waves. So press and hold, and you can see it's measuring 2 point something, 2.3, 2.2, 2.1, 2.3, 2.4, gathers 10 seconds of information, and then it decides what it should be. So 2.4, a third of that is exactly 0.8, which is exactly what we've got. But the word auto has appeared by the side of it. And what that means is you can't really change that value now. It's going to track the P wave. So if I try to rotate the control, I can't change the sensitivity. And that's why it's important to know if somebody switches on the auto, you can recognize it straight away because next to the sensitivity, you will see the word auto. So what's the effect of that? So let's have a look. I can change the height of my P wave. So I'm just going to pull up another menu here. So let me just move this out of the way. And currently I've got a 2.5 millivolt P wave that matches what we measured. But I'm going to change that to something dramatic like 6. So let's say my P wave now goes from 2.5 to 6. And I have to apply it. And what you'll notice is it immediately starts to change all on its own. It goes up gradually to a third of the height of the measured P wave. There's some slight differences between the actual number, the absolute number, and what it measures, but you can see that it's gone up, and that's because it's seen a bigger P wave. And let's say a little bit later the P wave comes down. So I'll just take the P wave down a bit. Let's take it down, back down to 2.5. And I apply it, and you can see straight away it starts to come down. There's my P wave, 1.2, 1.0, 0.9, 0.8, which is where we started when the P wave was originally 2.5. So it tracks. So when you have your patient in a mode where the intrinsic is there all the time, this is pretty easy to do. But what if you're pacing, and particularly in AAI, you do tend to drive the AAI patients quite hard. So let's put the pacing up, put it up to 90 beats a minute. We're pacing now, but it doesn't use the paced P wave for anything. Because the paced P wave is going to look completely different to the pacemaker than the intrinsic waveform. So it doesn't measure the paced P wave, it only measures the intrinsic P wave. So let's say we've paced for a whole day and we've got the auto on, we've paced for a whole day, and then you're going to do your sensing check. Well, now the sensing check is really easy because all I have to do is to take the rate down, or I can use the pause button, does the same thing. I take the rate down and something below the intrinsic, and what will happen is the P wave will be adjusted to whatever the new the sensitivity will be adjusted to whatever the new P wave actually is. And we can demonstrate that quite nicely. I'm going to put this back to 90. So whilst it was pacing at 90 beats a minute, let's say the P wave increased to 6. I apply it. It doesn't do anything here because it can't see the intrinsic P wave. It only knows that it's pacing. But the intrinsic P wave has gone up to 6. So now it's the next day, you come in, you want to do a sensing check. All you do is you take the rate down, something below the intrinsic, and you see straight away it starts to adjust. And it's going to come to something like a third of the measured P wave. So I'll let it do its thing. It's automatically adjusting, and then you just move the rate back up again. And so for the next day or shift or however often you do your checks, it will leave the sensitivity at 1.8. And during the night, let's say that 6 millivolts goes back down to 2.5 again. There we go. It's gone down to 2.5. You don't know, the patient doesn't know, the pacemaker doesn't know, nobody knows. But the next day when you do your sensitivity check, all you do is take the rate down to something below the intrinsic, and you can see that the sensitivity immediately starts to come down on its own and adjusts. I'll let it get down to 0.8. There we go, so 0.8. And when it's stable, you just take the rate back up again. So it's a really easy way of adjusting the sensitivity in the patient. And it does exactly the same thing in the ventricle. You just have to have the ventricular box ticked in dual chamber mode or in VVI mode if that's the mode you're in. Okay, I've only got two other things to talk about very quickly, and then we'll do some Q&A if anybody's got any questions. So let's just put this back where it was. I've got 2.5. There we go. That's done. I've got no blocks. I've got my rhythm is still at sinus, and I'm pacing at 90 beats a minute. Emergency pace. This red button here is for the situation where I have asystole, and I don't know why. I can see pacing spikes on here, but there is no blood pressure. We don't know really what's going on. You call the crash team, so the person closest to the bed will call the crash team because there's no output. Um, you know that it is not the patient pulling the wire out. And the reason you know is if you do pull the wire out, the box makes a noise. And let me just put this back here. That's the ventricular wire, by the way. So I'll just put this back. If the patient pulls a wire out, the box will make a noise and it will tell you that the atrial lead is disconnected in AAI mode. So you know that this flat line is not caused by a lead coming out of the heart or a lead coming out of the box. So what is it? The chances are that it's some kind of infarct in the proximity of the wires, which is preventing the current getting to good conductive tissue. And so what the box does when you press that red button is it will make the outputs go to 18 volts, both chambers, DOO. It doesn't matter what mode you're in. When I press the button, it's DOO, 18 volts, both chambers at 80 beats a minute. And the idea is that this will drive the current through the infarcted tissue or the infarcted area and out the other side into good conductive tissue. And it is possible you might get the patient back even before the crash team have arrived. It's not guaranteed because you've no idea how big the infarct is or how big the area is that's affected. But sometimes this will work. And you can see the sensitivities have been switched off. And then you stand back, let the crash team do their work. And the one thing I would say is if ever you press the red button, you need to tell somebody because everything will change. The thresholds, the sensitivity, the impedance, everything changes. And don't be in too much of a hurry to change your 18 volts back down to a low voltage because you may find that your thresholds are at 17 volts or 17.9. You might be hanging by a thread there. So I would keep it at 18 volts for as long as you can, or at least until the patient is stable, and then bring your sensitivities back. Bring those back first to something quite reasonable. So I'm going to say 2 in the ventricle. I'm going to come back to about a half in the atrium, or if you can see the note from the notes what the values were, set them back to the same values. I think we said this was 1. I'll set it back to the same values, 1.8 I think we said. And this was 3. But you'll notice that when you hit the red button, if you have auto on, auto is now off. So auto has to be reset again. And that's all to do with safety because everything will have changed. You need to make all those measurements again. Leave the outputs at 18 volts for now, and then when the patient's stabilized, bring these down to something reasonable, something significantly bigger than the threshold. So I'm going to put these back to 5. Okay. And the last thing now is turning off the device. So turning off the device. What I would do is, in most hospitals now, when you're finished with the box, you still leave it connected for a little while, and that's okay. And in fact, that's encouraged. If you're finished with the box, the chances are you've brought the rate down, to see if there's an underlying rhythm, and the underlying rhythm should be quite nice and good. And I can see, yeah, I've got a nice underlying rhythm there. And you might see that going for a little while. But if you're going to leave the box connected, don't turn it off. Put it into standby. And the way you do that is you go off, and there's two choices. Off means off, and when you turn it on, it'll come back in default, or standby. So I'll put it into standby, and it turns the device off, but not quite. It remembers everything. It remembers how it's programmed. It remembers what you have programmed into the device, the PVARPs, anything that you've changed. It remembers all that stuff, but it's not actually monitoring the patient at the moment. You look away, you look back and find that the patient is going at 20 beats a minute. You need pacing and you need it now. So you just hit the on button, and within 4 seconds, the device will come back exactly as you left it. And this is exactly as we left it. So it's standby is a very safe way of winding down pacing for this particular patient. If you've disconnected it from the patient, then you can then turn it off. So the way you would do that is you would go to off and off. And that means that it turns it off, it doesn't remember anything, and then then gets rotated back to theatres, and the next time it's turned on, it will come back in DDD mode at whatever the turn on parameters are for your hospital.